In that case, let's switch gears, talk about Parkinson disease. The rest of the morning will be spent on Parkinson disease because that's most common movement disorder. And basically, we'll talk about treatments and clinical trials, and we'll talk about physical therapy, speech therapy for Parkinson disease as well. So I'll have some guest speakers to join me. But first, let's just mention that this is a second most common neurodegenerative disorder. It affects 1% of people over age of 60 with in the United States. It results from depletion of dopaminergic cells in substantia nigra. That's the area of the brain deep in the brain. I'll show it to you. And there are some Lewy body inclusions. So not to be confused with Lewy body disease. I want to make a direct distinction. Lewy body disease is not Parkinson disease. You can see Lewy body in Parkinson disease, but only in only specific places of the brain. Whereas Lewy body disease, it's a widespread distribution of the Lewy body everywhere in the brain. So that different disorders, and the prognosis is different, treatment is different. So Lewy bodies can be seen in the certain cells of the brain in Parkinson disease, but limited to certain part of the brain. So characteristics, Dr. Caput already mentioned, the stiffness, slowness, resting tremor, classic, but you don't have to. 25% of patients with Parkinson disease never have tremor in their life. So that's doesn't have to be. And there is a response to levodopa also. Now that's like picture from the textbook showing that you can have a little bit of stooped posture, you can have reduced arm swing, you can have a little bit of shuffling going on, stiffness, you might not. So it is just kind of textbook a picture. They put everything together, but it's disease is very diverse. So whatever happens to one person doesn't happen to the other person. As Dr. Caput mentioned, no two similar patients in the world with exactly the same thing. Other features can include masked faces, decreased facial expression, smaller handwriting, changes in blood pressure, and depression, as Dr. Caput also mentioned, can occur in Parkinson's disease. And in fact, there is a 2% risk of developing depression per year, someone who has Parkinson. Now, freezing and fall. So freezing can occur as well, which is when you have sensation that your feet get stuck to the floor. Falls can occur as well, and physical therapy is very helpful. Medications do help for stiffness, slowness, and a little bit of tremor. The medications don't help for the balance, unfortunately. So the non-motor manifestations potentially can include memory issues, not immediately. 20 years down the road, you might notice some memory problems. It's not Alzheimer's disease. You'll never forget your relatives. It's just you might be a little bit confused, but it is not Alzheimer's disease, different type of memory problem. Constipation can occur. RBD stands for REM sleep behavioral disorder, kicking and screaming at night, which can precede the motor onset of Parkinson's disease by years. So people might notice that they kick and scream at night, and then 20 years down the road, they don't have to, but they might develop Parkinson. Drops in blood pressure as well. These are the medications I put, existing medications that we have now approved, FDA approved for these symptoms. So for hallucinations, psychosis, quetiapine, or newer version, the approved is called Nuplazid. For memory loss, it's rivastigmine or Exelon patch or donepezil. For orthostatic hypotension, the new one is called Northera. Or people can use fludrocortisone and midodrine if you have drops in blood pressure. For constipation, it's Miralax on Linzess. Recently was found to be very helpful. And for REM sleep behavioral disorder, clonazepam. That's probably the only one that helps greatly. Now, let's look at this slide. This is just to show you the conventional, the old school treatment of Parkinson's disease motor symptoms. So L-DOPA has been around since 1968. Then dopamine agonists include pramipexole and rapinirole. This is the actual precursor of dopamine. It's converted in dopamine in the brain. This class dopamine agonists, they essentially mimic dopamine and stimulate production of more dopamine in the brain. These are the selegiline, razagiline. It's an MOB inhibitor, monoamine oxidase B inhibitors. They prevent degeneration or degradation of the dopamine, both your own dopamine and from the medications. So the dopamine stays around longer and works stronger. Entacapone and tolcapone, these are COMT inhibitors. So they also do similar thing that MOB inhibitors do. They prolong the action of carbidopa, levodopa. And trihexyphenidyl, very old medication, is used. Could be used for tremor in Parkinson's disease. In fact, it works for tremor better than anything else, but it has dose-limiting side effects. So, namely, you can have memory problems, you can have constipation, you can have dry mouth from as a side effect. So, in older people, meaning anybody over age of 50, I wouldn't use that medication. Amantadine is a dirty drug. It has a lot of mechanism of action. It was approved for Parkinson's disease, used for tremor occasionally, for any symptoms, but we don't use it now for anything except for involuntary body movements called dyskinesias. So for this, it is helpful. Now, before we talk about new medications that are newly approved and the ones in clinical trials, just want to mention something about wearing offs. So wearing offs is after a few years, levodopa stops lasting forever, meaning the duration of action shortens. So it only lasts for let's say 4 hours or 5 hours, and then 4 hours, and then 3 hours. So that's considered wearing off. So what we traditionally have been doing, I mean, you can ask someone to take levodopa more frequently, or you can switch to longer acting version of levodopa, such as the newly approved medication called Rytary. You could add any of those previously mentioned classes, dopamine agonist and the inhibitors of the degradation of the dopamine. That will increase duration of the action. Increasing each individual dose of levodopa is not going to make it last longer. It will just be stronger when it works, but it's not going to last longer. So it's not the way to do it. Polypharmacy is used in treatment of Parkinson's disease. What I mean by that. So I would rather, instead of pushing that dose through the roof, I would rather use a little bit of that, a little bit of that, a little bit of that, or even a little bit of that. So the reason why is because you'll get less side effects because I'm using just a small dose, but different classes of medication to attack the disease from different angles, you know what I mean? So the polypharmacy is considered to be a good standard of care in treatment of Parkinson's disease. Also, if I don't use very high doses of levodopa, I will prevent this nasty thing called dyskinesia. So dyskinesia is involuntary body movements. You might have seen Michael J. Fox on TV when he's doing this business, and because he's been taking levodopa for 20 years, and that's a side effect of the medication. So received through email a question about when does it develop? What do we do about it? And does the dose matter? Yes, yes, and yes. So after 5 to 7 years of someone being on levodopa, dyskinesias usually develop. So it showed that after 5 years, 50% of patients taking levodopa develop some degrees of dyskinesia. At 10 years, it's like 80%. But these are all averages. So there are some patient-related risk factors, such as younger women. Younger women tend to develop more dyskinesias than men. The older you are, the less likely you are to develop involuntary body movements. So that's all averages. So someone who is 80, unlikely to develop dyskinesia as much as if they were 50. So that's why Michael J. Fox has so much of it, because he was 30 when he developed disease. And the higher the dose of levodopa, the more likelihood of developing dyskinesias. The study showed that beyond 400, actually not 300, but 400 milligrams daily, that results in exponential increase in the risk of developing dyskinesias. And management, amantadine, that's a traditional, but now we have new version, long-acting amantadine, Glycavri, and Osmolex ER. I'll mention about them a little bit later. Other treatments for dyskinesias and other things could be medicinal marijuana. So medicinal marijuana has been studied for Parkinson's disease, and the data is mixed. So there are two studies. One of them showed some improvement in tremor, anxiety, sleep, and REM sleep behavioral disorder, meaning kicking and screaming at night. The other study showed that there is a possible improvement in slowness, stiffness, and involuntary movements. In my experience, what patients have been, my patients who are taking medicinal marijuana, their anxiety, sleep, and dyskinesias get better. The stiffness and slowness, I'm yet to see improvement in those two domains, but some data shows that it does improve. So I do not prescribe medicinal marijuana, so you would need to see a pain management doctor who can do it. It's basically there are two ways. You can either take just CBD oil, that can be helpful for sleep, and it doesn't have that other THC component that gives you high. So, but that for sleep, it's good enough. If you want to improve your tremor and involuntary body movements, you have to have a little bit of that THC component in your mixture of CBD. And the pain management doctors usually do prescribe that. I can give you names of those who do prescribe if you want to give it a try. Now, let's talk about newly approved newly approved treatments. So Rytary, so that's a long-acting levodopa, was approved, and some people like it, some people don't like it. So you still take it 3 times a day, but instead of taking it 7 times a day, you might want to you might be able to take it 5 times a day. Or instead of 5 times a day taking levodopa, you might take Rytary only for 3 times a day. Now it's the same medication as levodopa, just formulated in a way that it lasts longer. Imbred, that's newly approved medication. It's inhaled levodopa used for freezing, not freezing episodes, but off episodes. So basically, it's not available in pharmacies yet, but they're taking prescriptions already. Next month in March, it will be available. So if you suddenly notice that the medication stops working and you need a rescue dose. Conventionally, we ask people to take additional dose of levodopa and chew it. And that does help, but takes maybe 45 to an hour to kick in. This one shows that in 30 minutes you have significant improvement. You also have improvement in as early as 10 and 20 minutes, but 10 and 20 minutes were not statistically significant from placebo. So the 30-minute improvement was statistically significant from placebo. That's the data. But it is approved now, so I can start prescribing it if you want to give it a try. Xadago, some of you are on it. It's a newly approved MOB inhibitor. The older version was Selegiline and Razagiline. There's no head-to-head data comparing the two, so I cannot tell you if Xadago is better than the generics. All I can tell you is that's once-a-day treatment, doesn't have any dietary restrictions, and you can be taken together with antidepressants, as opposed to Selegiline, where pharmacists always flags that and calls me, oh, if patient is taking antidepressant and you're giving them, Selegiline, how can you? So it's okay as far as I'm concerned, but officially it's a red flag. Glycovri, it's a long-acting amantadine, and so is Osmolex ER. These are competing 2 drugs. Once a day instead of 3 times a day. Regular amantadine is taking 3 times a day. That's just once a day formulation. Northera is used for drops in blood pressure. It's also newly approved medication, and it prevents drops in blood pressure. Apparently can be combined with fludrocortisone, but not with midodrine. Nuplazid was approved 2 years ago as antipsychotic, approved for treatment of hallucinations and Parkinson disease. Starts working at week 6. So basically for 6 weeks it's just kicking in and people having continuous symptoms. So that's a limitation of that drug essentially. There is also a patch called Neopro. That's the dopamine agonist patch. I didn't mention here because it's not new. It's been around for, even though it's a brand name, it's been around for years, and some of you are on it. But it's not that new. New, I mean, in the last 2 years or so. So we'll talk about that. You can ask me questions about that. For sake of time, I just want to mention a couple of words about DBS. So he already mentioned to you, Dr. Kaplan, what it entails is basically they put in electrodes, 1 or 2 electrodes in the deep portion in the brain connected to the battery. And this is what the battery looks like. It's embedded in under the skin like a pacemaker. That's for Medtronic, but the similar looking battery can be, obtained from St. Jude's, as someone asked earlier. And that's what I wanted to concentrate on, because Dr. Kaplan, I don't know if he had time to explain to you. So you have to have a clear diagnosis of Parkinson's disease. So if you have atypical Parkinson's, such as multiple system atrophy or progressive supranuclear palsy, these are rare, very rare, but you would not get better from that surgery. So it has to be just a regular Parkinson's disease, with or without tremor, and I'll be able to tell you that. Now, you should demonstrate good improvement of your symptoms with levodopa, because that would prognosticate your improvement with DBS. Improvement not necessarily in tremor, but stiffness and slowness. If it gets better, then DBS is a good thing for you, potentially. Then you might have problems such as motor fluctuations, disabling tremor, intolerance to medication. Some patients just get nauseous and they can't take levodopa at all. They do get better from it, they just can't tolerate it. So that's what deep brain stimulation would be helpful for. So to continue on the good candidates, stable cognition. So if someone has dementia and or cognitive impairment, and we do DBS, the dementia will get much worse. So for your own sake, you don't want to get DBS if you have cognitive issues, and we screen everybody through a neuropsychological testing before we do the surgery. So that would not be missed, but you should be aware of that. Now, realistic expectations, good family support is very important. I had one patient who had DBS done, and she perceived it. I don't know if she was misled. She thought it was a cure for Parkinson's disease. She thought she didn't need to take any medications after that, and it's not true. So it did help her symptoms, but after a few years, she needed to take a little bit of medication. She was devastated. It's not a cure. No, it's not. This is just surgical treatment for Parkinson's disease, but it's not a cure. So you still will have to be on medication. I think 50% reduction is a little bit optimistic. I'm going to tell you it's 25% reduction in your existing dose, depending on the site of the brain. Some sites, such as globus pallidus, you wouldn't reduce your medications at all. You will still have to be on the same dose of medications. So no comorbid psychiatric behavioral problems. So this is not really true. Before, back in the day, we used that criteria to make sure you don't have atypical Parkinson that progresses much faster. So that was a rule to rule that out. We don't no longer observe that 5-year rule. So the window of opportunity. Meaning, like, when is a good time to have that DBS? Early on, later on? Do you wait and see what happens? So there is a window of opportunity. Clearly, if your pinky just shaking and that's it, you don't need to run to have the surgery done. If your medication is controlling your symptoms fine, you don't need to have the surgery done. But if someone is not able to walk and the balance is so bad, DBS, by the way, does not help for the balance, and neither do the medications, and they don't have tremor, then what's the purpose of doing DBS? They can just as well take the medication. So you want to do it when you start noticing symptoms that medications don't help you adequately with. And if you have wearing offs, the DBS can give you up to 4 hours of good time per day. So it will reduce dyskinesias. It can be used to reduce dyskinesia and will reduce wearing offs. And it works beautifully for the tremor. So that's just one video I want to show you. So someone is turning off that DBS, and that gentleman has Parkinson's disease. So you see stimulation is off, and that the tremor starts. That's a resting tremor. It's rare. Not many people have that bad tremor at rest, but some people do. Now the stimulation will be turned back on again, and then you see gradually the tremor subsides. Yeah. So then the other picture is this. It's also similar, just a different patient. They gave their consent to be videotaped, and that's part of the Movement Disorder Society video library. So these are not my patients. Sorry. Let's just...
Appropriate candidates for thalamic stimulation have disabling tremor from essential tremor or Parkinson's disease, which cannot be controlled with medication. All types of tremor can be treated with thalamic stimulation, including rest tremor, postural tremor, and action tremor.
Okay, so now expectations, I already mentioned that these are all the symptoms, and this, by the way, this presentation will be available online. It will be video recorded, and you can, I'm going fast through the slides because we're limited on time, but you can watch that later, and you'll see all these slides. So you can get improvement in all these symptoms that are listed here, including wearing off, stiffness, slowness, some dystonic symptoms of Parkinson tremor as well. The expectations should be realistic, meaning these symptoms, you're not going to get improvement in the following symptoms: speech, balance, memory. So these three things will not get better as a result of the DBS. Make no mistake about it. And autonomic systems symptoms such as drops in blood pressure also would not get better. Now, maintenance of DBS, we're going to skip that because he already mentioned the battery lasts 4 years, or you can do rechargeable, and you have to charge it not every day, so I think once or twice a week. Now, complications, hemorrhage, we talked about bleeding, 2%, not 1, 2% overall risk of bleeding in the brain. Some of that could be incidental. They just take a picture after the surgery, they see a little bit of blood, nobody knows about it, meaning it doesn't affect the patient. Or it could be bad, as he mentioned. It's very rare that like causes weakness and so forth. Infection, he mentioned about like 5%. I personally never saw it. He had one incident. Device related, if let's say you have a trauma and you get in a car accident or whatever, this wire that goes from the brain under the skin to the chest can be broken. It would have to be replaced. And that's it. And we'll talk more if you want question and answer sessions about that. Then MRI guided ultrasound, you already mentioned. Just one word about that. One word about that is this. The ultrasound is the destruction of the brain. Deep brain stimulation is the stimulation of the brain, which can be adjusted. So what's done is done. If you have ultrasound, you burn that area of the brain, you cannot go back, you cannot increase it, you cannot decrease it. It doesn't cure the disease. It helps for the symptoms for some time, let's say 4 years. In 4 years, what do you do when the symptoms come back? There's nothing else to burn. So if you're younger and you're having symptoms, DBS would be a way to go as opposed to the ultrasound, because with DBS, I can always adjust the stimulation. Like I'm increasing your doses of medications, I will increase the parameters of the stimulation and to match the symptoms. If someone is 90, they have disabling tremor, they cannot go through this surgery. It might be too much for them. So the ultrasound might be a better way to deal with that, because they go home right away. There's no incision, no risk of infection. And, you know, it definitely would help them for 5 years. So as far as the bleeding in the brain, the risks of bleeding in the brain are identical in both procedures, even though in ultrasound, they don't cut your skin even, because that beam of the ultrasound burning the area of the brain can on its way burn some blood vessels and cause bleeding. Very rare, again, like less than 2%, but it's similar to DBS. Okay, so I think for questions, we'll combine after I have my colleague. Promising clinical trials. So I think we have to talk about that a little bit. We'll have to cut on something else, but I just want to go through a couple of things before we take a break. So symptomatic, a couple of things to mention on symptomatic therapies. So these, again, the chosen trials that I chose for you, because you need to be aware of that. Instead of DBS, there's an alternative. You can have a subcutaneous infusion of levodopa. So what it entails is that you have little pump here on your belt, and it's like insulin-like catheter, and the little needle goes under the skin, and it continuously secretes levodopa, and that results in reduction in fluctuations. So right now, they completed phase 2 trial. No, they say phase 2 ongoing, but they're finishing. They're not recruiting anymore. So watch out for phase 3. When phase 3 is out there, I would enroll. This is promising, because unlike the duodopa, which is approved, I wouldn't use that, because they put actually like a feeding tube almost in your stomach and infuse through that. The tube comes out, it leaks, it's messy. This one is, if the needle comes out, you just take it and put it back in. It's under the skin. It's very simple. As opposed to the tube, you have to see gastroenterologist, go to emergency room, have it installed again. So this is much easier. So we'll have phase 3 starting pretty soon, I hope. The phase 2 is finishing up. So that could be alternative, or in patients who really bothered, it could be used in addition to DBS, potentially. Okay, the other things, new Rytary is coming out. So they're doing clinical trials. Phase 3 is on the way for new Rytary, that will take it like once or twice a day. Then there is a sublingual apomorphine that was being developed, that it's like dopamine agonist. You put that under the tongue and it melts to unfreeze you, but it was put on hold by the FDA months ago, so there will be delay in approving it. Neurocrine is coming out with the new COMT inhibitor. You might have heard of entacapone. Some of you are taking it. So they're developing opicapone, which will make levodopa last even longer. So that's phase 3 is finishing, so probably would be approved either late this year or beginning of next year. Gene therapy, just to mention a little bit about it, this is not for cure of the disease. This is just to prevent wearing off. So what they do a surgery, they drill a hole in the head, they put little They put little catheter in there and, the syringe, and inject that gene in deep portion of the brain. And that's designed to improve wearing offs and motor fluctuations in Parkinson's disease. So Voyager Therapeutic is conducting these gene therapy trials. So recruiting, but again, this is not a cure for that. This is just to make levodopa last longer. You still have to take levodopa. Non-motor trials important. So Eli Lilly, they're recruiting for trials of Parkinson's disease who have dementia-like symptoms. So that's the component. That's the name of the drug they're studying. It's a phase 2, 12-week study they're recruiting. The Linzess, the study was retrospective. They just looked at the patients who were taking Linzess comparing to just Miralax, and that's Motegrity, another constipation medication, and was found to be superior than Miralax alone. So that is approved already, and these two medications can be added today. I mean, they're out there, but they looked retrospectively on patients with Parkinson's disease. There was no placebo because it was retrospective study, naturally.